You're listening to This Week in Cardiology from theheart.org on Medscape.
Hi, everyone. This is John Mandrola from theheart.org Medscape Cardiology, and this is This Week in Cardiology for March 30th, 2018. This week, I'm going to talk about heart failure care, methamphetamine, AF ablation, lead extraction, and myocardial injury after noncardiac surgery. First up is heart failure care. Now, I like to report good news in the care of patients with heart failure. In JACC Heart Failure, Korean investigators asked whether the time to diuretic treatment made a difference in outcomes. They enrolled about 5,000 consecutive patients hospitalized for acute heart failure. They separated the groups into those that got diuretics in less than 60 minutes and a group that was greater than 60 minutes after presenting. In-hospital death occurred in almost exactly the same, 5.0 versus 5.1%. Obviously, no difference. Also, they found no difference in death at 1 month. Now, this was not an RCT, but they did do multivariate analyses with adjustment and propensity matching, but still found no benefit. I call this good news because if this study were positive, I fear we would have to deal with another quality measure. And I'm pretty sure that most quality measures make heart failure care even more heartless than it already is. Yes, of course, patients with congestion should be treated, but there's time to think about things and assess the situation. Second topic is methamphetamine. Now, one of the reasons I include certain topics on this podcast is if I learn something new. A paper presented in JACC Heart Failure on the effects of meth on the heart taught me something. I learned that two big ways methamphetamine affects the heart, and I have actually seen both of these in clinical practice. The first is a meth-induced pulmonary hypertension, and the second is a meth-induced cardiomyopathy. The pulmonary artery hypertension disease seems to be female-dominant, while more males get the meth-induced cardiomyopathy. The mean ejection fraction in this descriptive study of 356 patients in the group that got cardiomyopathy was very low at 25%. And the mean PA pressure in the group of meth patients who had pulmonary artery hypertension was quite high at 75. And I thought to myself, this is a significant amount of disease. The mortality, too, at 20 months was high, 18% and 15.2% for the cardiomyopathy and PAH groups, respectively. Associated alcohol use was a factor in the CMP or cardiomyopathy group. Now, the putative mechanism is cardiotoxic effects by stimulating release of catecholaminergic neurotransmitters in both the central and peripheral nervous system, and these modulate heart rate and blood pressure. I don't know about your practice, but here in Kentucky, the opioid problem gets most of the attention. But this paper presents daunting facts on meth use. The fact that meth-induced disease has less immediate effects than opioids on mortality. Meth causes severe and delayed effects on the heart and pulmonary arteries is quite sobering and requires more attention. Third topic today is apixaban use during AF ablation. Now, guidelines recommend using continuous oral anticoagulation during the perioperative AF ablation procedure. But apixaban had not yet been studied, so now it has. In the European Heart Journal, multiple investigators report findings of an apixaban versus warfarin study. Now, this had about 674 patients in it, where the primary outcome was a composite of death, stroke, or major bleeding, and it showed no significant difference. Of note here was that the absolute numbers of complications were quite high. Get this, 6.9 and 7.3%. Yes, they were equal, but how many of us, quote, risk of ablation of 7%. And these were pretty high-level expert centers who enrolled patients in this trial. This study also had a nice twist looking at acute small brain lesions, and they were found in the same number of people in the apixaban versus warfarin group, about 1 in 4 in each group. The MRI part of this study was a sub-study that involved about half of each of the groups enrolled in the trial. The conclusions from the authors were that apixaban is safe and effective in regard to bleeding, stroke, and brain lesions during AF ablation. The authors do comment, and I think appropriately, that further research is needed to reduce ablation-related brain lesions. Now, I've said this before about these brain lesions. One approach to them is to say, don't worry, they go away with time and they occur with any cardiac procedure. That's sort of a doctor-centric approach. The patient-centric approach is like, crap, you mean having ablation means I have a 1 in 4 chance of sustaining brain lesions or brain injury? I think this deserves more attention, these cerebral lesions during AF ablation. The next topic has to do with lead extraction. Now, lead extraction of cardiac pacing leads is a tough problem. The leads become attached to the veins and to the heart, sort of adherent to the SVC and other veins and cardiac structures. There are 2 major techniques for undoing the lesions and removing the leads. One is with a mechanical rotating sheath, and the other is with a laser sheath. Both of these are tools during the lead extraction process. A company called Spectranetics makes the laser sheath and has been active in training many implanters to do lead extraction. Well, an interesting and provocative meta-analysis presented at ACC from a group at University of California at San Francisco suggested a 9-fold higher rate of death when laser sheaths are used compared with older mechanical rotating sheaths. The meta-analysis culled 14 studies of 19 patients that used the rotating sheaths and 33 studies of 7,800 patients that used the laser sheaths. Now, most of these studies were case series and not really randomized controlled trials. The non-randomized groups in this meta-analysis were mostly similar, although the rotating sheath group were slightly older, but also had fewer ICD leads. The success rates were similar, over 90%, but get this, there was 1 death with the rotating sheath group and 66 deaths in the laser sheath group. That's 0.09% versus 0.85%, or a 9.3-fold higher risk in the laser sheath arm. I mean, this is worrisome. The UCSF group reported a poster at AHA that also found higher death and complication rates from the laser sheath, but that study was criticized because it used data from the MAUD database. And the MAUD database is self-reported and free of denominators, so everyone kind of agrees that the MAUD database is not a very robust way to find signals of harm. But this meta-analysis is certainly more rigorous than a review of the MAUD database. That said, it's very important to note that there could be confounding factors that explain the higher death rate. I'd say they're even likely confounding factors. There's also not really a control for the center's experience or the doctor's experience with the procedure. I think at minimum, though, this work deserves a follow-up study. A high rate of death from laser sheaths is plausible. I mean, if you think about it, whereas a mechanical sheath can do only mechanical harm, a laser sheath can cause both thermal and mechanical harm. Also, I think, provocatively, a laser sheath allows less experienced operators to perform extraction. My overall take of lead extraction is it's similar to AF ablation, namely, we have too many hospitals and operators doing it. But that's the problem with our healthcare system. Instead of letting a few experts do the majority of cases, we train many operators to do the procedure. We keep the procedure in-house. This means that we have much of the procedures being done at low-volume centers. It's a classic example of supply-driven services. The more supply of lead extractors there are, the more the extractions get done, and this is not necessarily a good thing. Next topic is myocardial injury after non-cardiac surgery, so-called MINS. Canadian investigators decided to investigate the treatment of this increasing problem of MINS, which is MI following non-cardiac surgery. As patients in the hospital get sicker, and as the troponin assays become more sensitive, we will see more of MINS. Of note, myocardial injury after non-cardiac surgery does not include non-ischemic myocardial injury such as sepsis and rapid AFib and chronically elevated troponins. And previous studies show that MINS associates with an increased risk of cardiovascular events and death over the first 2 years of surgery. So this is a predictor of major adverse cardiac events. This study, this managed study, was a 2x2 factorial design in patients with MINS. It was dabigatran versus placebo and omeprazole versus placebo. The omeprazole versus placebo arm of this trial was not reported at ACC, so we don't have that data yet. So we're talking mostly about placebo versus omeprazole. 80% of patients enrolled in the managed trial got in with troponin criteria and 20% got in with standard MI criteria. And the trial, unfortunately, was redesigned midway through due to slow enrollment. The sample size was reduced from 3,200 to 1,750, and the primary outcome also changed to now include a composite of vascular mortality, non-fatal MI, non-hemorrhagic stroke, peripheral arterial thrombosis, amputation, and symptomatic VTE. This was a truly global trial where countries all over the world were enrolling patients. And sadly, though, permanent drug discontinuation occurred in 46% of the DABI group and 43% of the placebo group. The primary outcome occurred in 11% in the DABI group versus 15% in the placebo group, and that p-value was 0.012, so it was statistically significant. The primary safety outcome was no different, 3% versus 4%, and the statistics on that was essentially non-different. So patients who have MINS are at substantial risk of vascular complications. Without routine postoperative troponin measurements, clinicians will not recognize MINS. And among patients who had MINS, dabigatran 110 milligrams BID resulted in a lower risk of major vascular complications compared to placebo. These were the conclusions of the authors. Now, my comments is, first of all, this study is not yet published, and the dropout rate could be a fatal blow. I mean, when the number of patients dropped a study's drug is far more than the difference, it's hard to make definitive conclusions. And the differences in outcomes with dabigatran were quite modest. And the other question is, how does one posit benefits without any increased risk of bleeding? This is different than many other trials with antithrombotic agents. And with antithrombotic agents, you get a reduction in outcomes, but usually there's a increase in bleeding, and we didn't see this in this trial. Finally, I think we're just at the cusp of understanding what to do with these expanding groups of patients with myocardial injury after non-cardiac surgery. So stay tuned for more on that. And so that's it for this week in cardiology. I'm really grateful that you listened. Thank you. Until next week, this is John Mandrola from the heart.org Medscape Cardiology.
You're listening to This Week in Cardiology from the heart.org on Medscape.